Question 1. A 45-year-old female patient presents with a history of hypertension, diabetes, and obesity. She has been diagnosed with essential hypertension like 10 code, type 2 diabetes mellitus E.9, and morbid obesity 0.1. During the encounter, the physician also documents that the patient has a recent history of depression but does not address the condition during the visit. How should the coder handle for this encounter, and which of the following conditions should be coded? A. Only essential hypertension, it should be coded. B. Only type 2 diabetes mellitus E.9 should be coded. C. Essential hypertension, type 2 diabetes mellitus E.9 and morbid obesity 0.1 should all be coded. D. Essential hypertension, type 2 diabetes mellitus E.9 and depression should be coded. Answer C. Essential hypertension, type 2 diabetes mellitus E.9 and morbid obesity 0.1 should all be coded. Explanation. According to ICD-10 coding guidelines, all diagnoses that are actively managed, treated, or affect patient care should be coded. In this scenario, essential hypertension, type 2 diabetes mellitus E.9 and morbid obesity 0.1 are all directly relevant to the care and should be coded. Even though depression is noted in the patient's history, it is not actively addressed during this encounter and does not meet the criteria for coding unless it is actively treated or discussed during the visit. Therefore, the correct response is to code for hypertension, diabetes, and obesity. Question 2. A 32-year-old male patient presents to the emergency department with a laceration on his forearm that occurred when he accidentally cut himself while using a knife. The wound is approximately 5 centimeters in length and is sutured by the physician. The patient is also diagnosed with an acute sprain of his left ankle, which occurred during the same incident. How should the coder assign the appropriate ICD-10 codes for this encounter? A. 0.80 UNCSA, laceration of the forearm, and S.400 Levina, sprain of left ankle. B. S.80 UNCSA, laceration of the forearm, and S.413, sprain of right ankle. C. S.80 TUXA, laceration of the wrist, and S.400 Levina, sprain of left ankle. D. 0.80 UNCSA, laceration of the forearm, and T.8 injury not specified. Answer A. 0.80 UNCSA, laceration of the forearm, and 0.400 Levina, sprain of left ankle. Explanation. The patient has a laceration of the forearm, 0.80 UNCSA, and a sprain of the left ankle at 0.400 Levina, both of which occurred during the same incident and are appropriately addressed in this coding scenario. The ICD-10 code for the laceration of the forearm is 0.80 UNCSA, and for the sprain of the left, it is S.400 Levina. The encounter should include these codes, reflecting the injuries treated. It's crucial to ensure correct sequencing of codes in case like this, especially in emergency department settings where injuries are handled concurrently. Question 3 scenario. Mr. James, a 50-year-old male, visits his physician for a routine checkup. During the visit, the physician documents the following conditions: a past history of gastric reflux ICD-10 code K.9, hypertension and asthma J.909. The physician also notes that the patient is currently experiencing a flare-up of his asthma. What is the most accurate set of codes for this encounter, and should the physician's note be reflected in the coding? A. K.9 and J.909 only as asthma is not being actively treated. B. K.9 and J.901 asthma exacerbation to indicate the active flare-up of asthma. C. K.9 and J.909 only as the flare-up does not need to be coded. D. K.9 and J.909 and code for the routine checkup. Answer B. K.9 and J.901 asthma exacerbation to indicate the active flare-up of asthma. Explanation. In this scenario, it's important to recognize that the physician specifically notes that the patient is experiencing flare-up of his asthma, as asthma is actively being treated during this encounter. The correct coding would include J.901 for the asthma exacerbation. The other conditions, gastric reflux K.9 and hypertension A, should also be coded since they are part of the patient's medical history and are relevant to his current care. Routine checkup code would not be appropriate unless preventive or general health checkup was the primary reason for the visit, but in this case, the focus is on the active medical issues. Therefore, the correct answer is to include J.901, indicating the exacerbation of asthma. Question 4. A 60-year-old female patient presents to her primary care physician for a follow-up visit after undergoing surgery for breast cancer. She is currently in remission but is receiving chemotherapy treatments as a preventive measure. The physician documents a history of breast cancer ICD-10 code C.919 chemotherapy Z.11 and mentions that the patient has been experiencing nausea and vomiting related to the chemotherapy. How should the medical coder assign the correct ICD-10 codes for this visit? A. C.919 is a .11 and R.0 nausea. B. C.919 is a .11 and R.2 nausea with vomiting. C. C.919 and Z.11 only since nausea and vomiting are not related to the chemotherapy. D. C.919 Z.11 and R.9 unspecified nausea and vomiting. Answer B. C.919 Z.11 and R.2 nausea with vomiting. Explanation. The physician documents the patient's history of breast cancer C.919 chemotherapy treatments to .11 and a current condition of nausea and vomiting due to chemotherapy. According to ICD-10 coding guidelines, nausea associated with chemotherapy is specifically coded as R.2. With vomiting, it's important to select the most accurate code for the nausea and vomiting symptoms, which is R.2 rather than R.0 nausea alone or R.9 unspecified nausea. The chemotherapy is correctly coded with Z.11, which is used to reflect the patient's current treatment plan. Therefore, the correct coding for this visit is C.919 to .11 and R.2. Question 5. A 28-year-old male patient presents to the emergency department after a motorcycle accident. The patient is diagnosed with a right femur fracture, a .1, left wrist sprain, a .501, and contusions of the abdomen, a .0. The physician also documents that the patient is a smoker and has a family history of lung cancer. How should the coder assign the appropriate ICD-10 codes for this encounter? A .1, a .501, and S.0 only. B. A .1, a .501, a .0, and Z.820 personal history of tobacco use. C. A .1, a .501, a .0, and Z.0 family history of malignant neoplasm of the lung. D. S.1, a .501, a .0, and Z.0 tobacco use disorder. Answer A. A .1, a .501, and Z.0 only. Explanation. In this case, the focus of the encounter is on the motorcycle accident injuries, including the femur fracture, a .1, wrist sprain, a .501, and contusions of the abdomen, a .0. These are the primary conditions being treated during the emergency department visit and should be coded. Although the patient is a smoker and a family history of lung cancer, these conditions are not actively being treated during this encounter. Therefore, these should not be included in the coding for this particular visit. Codes like .820, personal history of tobacco use, and Z.0, family history of malignant neoplasm of the lung, are not relevant for this encounter, as they are not being addressed directly by the physician at the time of the visit. Question 6. A 48-year-old female patient with a history of chronic obstructive pulmonary disease (COPD) presents to the physician for routine care. The physician documents the follow-up for her COPD J.9 and mentions that she is currently taking inhalers and undergoing pulmonary rehabilitation. The physician also notes that the patient's COPD is stable and no changes in treatment are required at this time. How should the coder handle the ICD-10 coding for this encounter? A. J.9, COPD unspecified, it's a .89 encounter for other specified aftercare. B. J.9, COPD unspecified and .0 encounter for dialysis. C. J.9, COPD unspecified only. D. J.9, COPD unspecified, it's a .4 long-term use of inhaled steroids and .89 other specified aftercare. Answer C. J.9, COPD unspecified only. Explanation. In this scenario, the patient's COPD is stable and there are no changes to her treatment plan during the visit. Since the condition is stable and there is no indication of any active treatment or aftercare needs beyond the regular monitoring, the correct ICD-10 code is J.9, COPD unspecified. Additional codes like .89 encounter for other specific aftercare or Z.4 long-term use of inhaled steroids are not appropriate here, as they do not reflect the purpose of this visit. There is no indication that the patient is undergoing specific aftercare treatment or medication adjustment. Question 7. A 22-year-old male patient is seen in the urgent care clinic with a complaint of right lower abdominal pain. After a thorough examination, the physician diagnoses acute appendicitis K.80 and recommends immediate surgical intervention. The physician also notes that the patient is otherwise healthy with no significant medical history. How should the medical coder assign the ICD-10 codes for this encounter? A. K.80 acute appendicitis with unspecified complication only. B. K.80 acute appendicitis and Z.0 general adult medical examination. C. K.80 acute appendicitis and Z.0 personal history of appendicitis. D. K.80 acute appendicitis 0.0 general adult medical examination and Z.9 problem related to lifestyle. Answer A. K.80 acute appendicitis with unspecified complication only. Explanation: the patient is diagnosed with acute appendicitis K.80 based on the presenting symptoms and clinical examination. The physician recommends surgery, and this is the primary focus of the encounter. Therefore, the appropriate coding for this visit is K.80, which specifically describes acute appendicitis. The code Z. General adult medical examination and Z.0 personal history of appendicitis are not applicable here. Z.0 is used for routine preventive exams, and Z.0 is used for patients who have a history of appendicitis but are not currently experiencing an active condition. Therefore, the correct code is K.80 only. Question 8. A 35-year-old female patient visits her primary care physician with complaints of fatigue, shortness of breath, and dizziness. After thorough testing, the physician diagnoses anemia due to vitamin B deficiency D.9 and prescribes vitamin B injections. The physician also notes that the patient has a family history of hypothyroidism. How should the medical coder assign the correct ICD-10 codes for this encounter? A. D.9 vitamin B deficiency anemia as a 0.3 family history of endocrine, nutritional, and metabolic diseases. B. D.9 vitamin B deficiency anemia and E.9 hypothyroidism unspecified. C. D.9 vitamin B deficiency anemia only, as hypothyroidism is not being treated. D. D.9 vitamin B deficiency anemia E.9 hypothyroidism as specified, and Z.3 family history of endocrine, nutritional, and metabolic diseases. Answer A. D.9 vitamin B deficiency anemia Z.3 family history of endocrine, nutritional, and metabolic diseases. Explanation: in this case, the patient is being treated for vitamin B deficiency anemia D.9, and the physician has prescribed treatment in the form of vitamin B injections. However, the family history of hypothyroidism to 0.3 is relevant for coding purposes as it may impact patients' health in the future, but it is not actively being addressed during this encounter. The diagnosis of hypothyroidism E.9 is not applicable here since there is no indication that the patient is currently being treated for or diagnosed with hypothyroidism. Therefore, the correct coding includes D.9 for the anemia and Z.3 for the family history of endocrine disease. Question 9. A 55-year-old male patient presents to his physician for a routine visit. The physician documents the patient has a history of type 2 diabetes E.9, hypertension, and a history of stroke E.9, which the patient had several years ago. The physician notes that the patient is doing well with stable blood pressure and blood glucose levels. How should the coder handle the coding for this visit? A. 0.9 and Rolo.9 as the history of stroke is relevant to the current care. B. 0.9 and Roa inly as the history of stroke does not require coding unless it is active. C. 0.9 Ono.9 and Z.0 general adult medical examination. D. 0.9 and Z.41 overweight BMI 25.0 29.9. Answer B. 0.9 and Roa inly as the history of stroke does not require coding unless it is active. Explanation: in this scenario, the patient's type 2 diabetes E.9 and hypertension are actively managed conditions and they are relevant to the current care. However, the history of stroke Rolo.9 does not require coding in this instance because it is not currently affecting the patient's health and there are no complications related to the stroke during this visit. ICD-10 coding guidelines state that past medical conditions or personal history codes, LICRO or Z.9 for history of stroke, should only be coded if they are relevant to the current care being provided or if they affect the patient's treatment. Therefore, the correct code assignment includes only the active conditions, the 0.9 and A. Option is incorrect because the history of stroke .9 does not need to be included unless it is relevant for the encounter. Option C is incorrect because the .0 is used for general adult medical examination, which doesn't apply here since the focus of the visit is on managing the patient's chronic conditions, not just routine exam. Option D is incorrect because Z.41 overweight, BMI 25.029.9 is not relevant unless the physician explicitly documents BMI measurement that falls within this range, which is not mentioned here. Question 10. A 40-year-old female patient visits her physician with complaints of a persistent cough, fatigue, and weight loss. The physician orders a chest X-ray which shows a suspicious mass in the lung. The physician documents a diagnosis of suspected lung cancer and refers the patient to a specialist for further evaluation. How should the coder assign the appropriate ICD-10 codes for this encounter? A. R cough R.83, other fatigue and R.5, abnormal weight loss. B. R cough R.83, other fatigues a .2 encounter for screening for malignant neoplasm of the lung. C. R cough R.83, other fatigue and C.90 malignant neoplasm of the lung, unspecified. D. R cough R.83, other fatigue and Z.89 encounter. Observation for other suspected diseases and conditions. Answer D. R cough R.83, other fatigue and Z.89 encounter for observation for other suspected diseases and conditions. Explanation. In this case, the physician has documented symptoms of a cough, fatigue R.83 and weight loss R.5, but has not yet confirmed a diagnosis of lung cancer. The physician has only suspected the presence of lung cancer based on the imaging findings and referred the patient for further evaluation. Therefore, the correct ICD-10 coding reflects the symptoms R.83, R.5, and the encounter for observation due to suspected conditions Z.89. Option is incorrect because it does not reflect the need for observation of suspected lung cancer. Option B is incorrect because the .2 is used for screening encounters and this patient has not yet been diagnosed with lung cancer. Option C is incorrect because C.90 malignant neoplasm of the lung should not be coded until the diagnosis is confirmed. Question 11. A 60-year-old male patient presents for a routine follow-up visit after undergoing a coronary artery bypass graft (CAG) surgery. The patient reports feeling well with no chest pain or shortness of breath. The physician documents the patient's medical history, which includes the CAG procedure Z.1 and hypertension. The physician also notes that the patient is prescribed medication for blood pressure management. Should the coder assign the ICD-10 codes for this encounter? A. Hypertension and Z.1, presence of coronary artery bypass graft. B. Hypertension, Z.1, presence of coronary artery bypass graft, and Z.899 other long-term drug therapy. C. Hypertension and Z.0 general adult medical examination. D. Hypertension and Z.4 long-term use of inhaled steroids. Answer. I. Hypertension and Z.1 presence of coronary artery bypass graft. Explanation. The patient's hypertension and the presence of coronary artery bypass graft, so .1, are the primary conditions being managed during this follow-up visit. The physician has documented that the patient is feeling well and is not experiencing any symptoms related to these conditions. The use of blood pressure medication is not specifically addressed. Encounter is part of the treatment plan and does not require additional coding in this instance. Option B to .899 refers to long-term drug therapy for other conditions, but there is no indication that the blood pressure medication is being managed in this visit. Option C is incorrect because the .0 is for routine preventive visits, which does not apply here since the visit is for follow-up care related to chronic conditions. Option D is incorrect because C.4 applies to long-term use of inhaled steroids, which is not relevant to this case. Question 12. A 70-year-old male patient presents with a complaint of frequent urination and a feeling of a complete bladder emptying. The physician orders a prostate-specific antigen SSA test which comes back elevated. The physician diagnoses benign prostatic hyperplasia BH and provides the patient with medication to manage the condition. How should the medical coder assign the ICD-10 codes for this encounter? A. N.0 benign prostatic hyperplasia with urinary retention. B. N.1 benign prostatic hyperplasia with low urinary tract symptoms. C. N.9 benign prostatic hyperplasia unspecified. D. N.0 benign prostatic hyperplasia with urinary retention and R.0 frequency of urination. Answer C. N.9 benign prostatic hyperplasia unspecified. Explanation. In this scenario, the patient is diagnosed with benign prostatic hyperplasia (BH), but there are no indications of urinary retention or specific low urinary tract symptoms documented in the encounter. Therefore, the correct ICD-10 code is N.9, benign prostatic hyperplasia unspecified. The physician did not provide specific details about urine retention or low urinary tract symptoms, so N.0 or N.1 would not be appropriate. R.0 frequency of urination is also not needed unless it is specifically documented as a distinct symptom requiring treatment. Question 13. A 45-year-old female patient with a history of hypertension and diabetes mellitus type 2E.9 presents for a routine follow-up visit. The patient's blood pressure is elevated and her blood glucose levels are slightly above the target range. The physician documents that the patient's conditions are not well controlled and adjusts her medication accordingly. The physician also orders laboratory tests for kidney function. How should the medical coder assign the ICD-10 codes for this encounter? A. Hypertension and E.9. Type 2 diabetes mellitus with additional codes for kidney function tests. B. Hypertension and E.9. Type 2 diabetes mellitus with a 0.4 long-term use of insulin. C. Hypertension and E.9 type 2 diabetes mellitus with Z.421 overweight BMI 25.0 29.9. D. Hypertension and E.9 type 2 diabetes mellitus with Z.89 encounter for observation for other suspected diseases and conditions. Answer A. Hypertension and E.9 type 2 diabetes mellitus with additional codes for kidney function tests. Explanation. The patient's conditions, hypertension and diabetes, are active and not well controlled, and the physician adjusts the patient's medication during the visit. There is no need to code for long-term use of insulin or overweight status unless specifically noted. While kidney function tests are ordered, they are not coded unless or further diagnoses related to the kidneys are documented. Question 14. A 38-year-old male patient presents with a complaint of chest pain. He reports a history of myocardial infarction 5 years ago and is currently receiving medication for hypertension. The physician documents the chest pain as non-cardiac and attributes it to anxiety. The physician recommends therapy for anxiety but advises the patient to continue taking his current medications. How should the coder? The ICD-10 codes for this encounter: A. Hypertension 0.10 atherosclerotic heart disease unspecified, and FF.9 anxiety disorder unspecified. B. Hypertension and F.9 anxiety disorder unspecified. C. Hypertension 0.9 coronary artery disease unspecified, and F.9 anxiety disorder unspecified. D. Hypertension or 0.10 atherosclerotic heart disease unspecified, F.9 anxiety disorder unspecified, and R.9 chest pain unspecified. Answer B. Hypertension and F.9 anxiety disorder unspecified. Explanation. The patient's hypertension is relevant to the visit. Although the patient has history of 0.10, the physician has ruled out cardiac causes for the chest pain and attributed it to anxiety, FF.9. There is no need to code for the chest pain, R.9, in this case because it is secondary to the anxiety diagnosis. The physician's note excludes new cardiac event or issue. Question 15. A 60-year-old female patient is diagnosed with osteoarthritis of the knee, MM.9, and she presents to her physician for a follow-up visit regarding the management of her pain. The physician notes that the patient is obese, BMI 32, and recommends weight loss to help reduce the strain on her knee joints. The physician also orders physical therapy for the knee pain. How should the coder assign the ICD-10 codes? Encounter A. M.9 osteoarthritis of the knee and E.9 obesity unspecified. B. M.9 osteoarthritis of the knee, 0.3 overweight and to 0.4 long-term use of insulin. C. M.9 osteoarthritis of the knee and Z.32 BMI 30.0 34.9 overweight. D. M.9 osteoarthritis of the knee and Z.3 dietary counseling and surveillance. Answer A. N.9 Osteoarthritis of the knee and E. Point 9 Obesity unspecified. Explanation. The primary diagnosis is the osteoarthritis of the knee MM.9. The patient's obesity, point 9, should be coded as it is contributing to the patient's condition. Weight loss counseling is included in the treatment plan but does not require additional coding unless a specific counseling code is documented. Option B is incorrect as long-term insulin therapy is not mentioned. Option C incorrectly uses a .32 for BMI, which applies only if the physician specifically documents the BMI range for the patient. Option D is incorrect because the .3 applies only if the physician documents a focus on dietary counseling rather than the osteoarthritis treatment. Question 16. A 50-year-old female patient presents with complaints of shortness of breath, fatigue, and swelling of her legs. The physician performs a physical exam and suspects the patient may have congestive heart failure, CHF. The physician orders an echocardiogram and schedules a follow-up visit for the results. How should the coder assign the ICD-10 codes for this encounter? R.0 shortness of breath and R.9 heart failure unspecified. B. R.0 shortness of breath throne loin 1 left ventricular failure and Z.0 general adult medical examination. Hero loin 9 heart failure unspecified and Z.89 encounter for observation for other suspected diseases and conditions. D. R.0 shortness of breath loin 9 heart failure unspecified and Z.89 encounter for other specified examination. Answer. E.09 heart failure unspecified and Z.89 encounter for observation for other suspected diseases and conditions. Explanation. The patient presents with symptoms of heart failure and the physician is conducting tests to confirm the diagnosis. Since heart failure is not confirmed at this point, the appropriate code would be M.9 heart failure unspecified. The encounter is for observation for suspected failure, so Z.89 is used. The use of R.0 is valid because the patient presents with shortness of breath. Option is not accurate because the diagnosis is not yet confirmed. Option B is incorrect because the .0 is for a general examination and EHF has not been confirmed. Option D is incorrect due to the misapplication of Z.89. Question 17. A 62-year-old male patient presents with a severe headache, nausea, and blurred vision. The physician orders OCAN and suspects the patient may have a stroke. The CT scan reveals a small infarction in the brain. The physician documents the diagnosis as acute cerebral infarction. The patient is admitted to the hospital for further evaluation and treatment. How should the coder assign the ICD-10 codes for this encounter? A.0.9 cerebral infarction unspecified and Roa.9 subarachnoid hemorrhage unspecified. Roa.9 cerebral infarction unspecified and Z.5 care involving the use of chemotherapy. C.9 cerebral infarction unspecified and Roa.91 sequelae of cerebrovascular disease. D.9 cerebral infarction unspecified and Roa.8 other cerebral infarction. Answer. D.9 cerebral infarction unspecified and 8 other cerebral infarction. Explanation. The patient has been diagnosed with an acute cerebral infarction, which is confirmed by the CT scan. The correct ICD-10 codes on LOIN-9 as the infarction type is unspecified. The choice for a LOIN-8 would be appropriate for a more specific diagnosis, but the physician's documentation simply mentions an infarction without specifying the exact location. Known .9 is used. Option is incorrect because M.9 is for a subarachnoid hemorrhage, which is not the diagnosis here. Option B is incorrect because the patient is not receiving chemotherapy. Option C is incorrect because M.91 is used for sequelae of cerebrovascular disease, which would only be relevant after the acute phase has passed. Question 18. A 28-year-old female patient visits her physician complaining of persistent pelvic pain. She reports irregular menstrual cycles and a family history of endometriosis. The physician suspects endometriosis and orders an ultrasound. The ultrasound results suggest possible endometriosis, but the physician does not make a definitive diagnosis at this time. How should the coder assign the ICD-10 codes for this encounter? N.9 endometriosis unspecified and N.6 excessive menstruation with irregular cycle. B. N.0 endometriosis of the ovary and N.6 dyspareunia. C. R.2 pelvic pain and N.9 endometriosis unspecified. D. N.9 endometriosis unspecified and Z.9 encounter for other contraceptive management. Answer C. R.2 pelvic pain and M.9 endometriosis unspecified explanation. The patient presents with symptoms that suggest possible endometriosis, but a definitive diagnosis has not been made. The correct coding includes R.2 for pelvic pain and M.9 for unspecified endometriosis, as the physician is considering this diagnosis. Options A, B, and D include incorrect codes based on the patient's symptoms and the physician's notes. Question 19. A 75-year-old male patient with a history of chronic obstructive pulmonary disease COPD presents to his physician with an exacerbation of shortness of breath, cough, and wheezing. The physician examines the patient and determines that the exacerbation is related to an acute respiratory infection. The physician prescribes antibiotics and increases the patient's inhaler regimen. How should the coder assign the ICD-10 codes for this encounter? A. J.0 chronic obstructive pulmonary disease with acute low respiratory infection, and J.9 acute bronchitis unspecified. B. J.1 chronic obstructive pulmonary disease with acute exacerbation, and J.9 pneumonia unspecified. C. J.9 chronic obstructive pulmonary disease unspecified, and J. bronchitis not specified as acute or chronic. D. J.1 obstructive pulmonary disease with acute exacerbation, and J. acute nasopharyngitis. Answer B. J.1 chronic obstructive pulmonary disease with acute exacerbation, and J.9 pneumonia unspecified. Explanation: the patient's COPD J.1 is exacerbated by an acute respiratory infection, specifically pneumonia. J.9. The correct ICD-10 code combination reflects the exacerbation of COPD and the acute infection. Option is incorrect because the acute low respiratory infection is not specified as bronchitis. Option C is incorrect because J.9 is for unspecified COPD, and the physician has noted an acute exacerbation, which is coded separately. Option D is incorrect because J is for common cold, not an acute respiratory infection. Question 20. A 40-year-old female patient comes in for a routine annual physical exam. The physician documents that the patient has a history of breast cancer C.919 and that she is currently in remission. The physician performs a breast examination and no abnormalities are noted. How should the coder assign the ICD-10 codes for this encounter? A. Z.0 general adult medical examination and C.919 malignant neoplasm of breast unspecified. B. To .31 encounter for screening mammogram and C.919 malignant neoplasm of breast unspecified. C. Is a .0 general adult medical examination and Z.3 personal history of malignant neoplasm of breast. D. Is Z.0 general adult medical examination and C.9 malignant neoplasm of breast unspecified. Answer C. Z.0 general adult medical examination and Z.3 personal history of malignant neoplasm of breast. Explanation: since the patient is in remission and the physician's notes indicate personal history of breast cancer C.919, the appropriate code is Z.3 personal history of malignant neoplasm of breast. The Z.0 code is used for general adult medical examiner. Options and D are incorrect because the patient's breast cancer is in remission and should be coded as history of the disease, not an active condition. Option B is incorrect because the encounter is for an annual physical, not screening mammogram. Question 21. A 50-year-old male patient with a history of hypertension and diabetes mellitus type 2E.9 presents for a follow-up visit regarding his management of chronic conditions. The physician adjusts his diabetes medication and recommends continued blood pressure monitoring. The patient reports no new symptoms, but the physician notes that the patient is not compliant with lifestyle changes. The physician or laboratory tests to assess kidney function due to concerns of diabetic nephropathy. How should the coder assign the ICD-10 codes for this encounter? A. Hypertension E.9, type 2 diabetes mellitus and Z.4 long-term use of insulin. B. Hypertension E.9, type 2 diabetes mellitus at .41, overweight, BMI 25.0, 29.9 and Z.4 long-term use of insulin. C. Hypertension E.9, type 2 diabetes mellitus and Z.2 long-term use of oral hypoglycemic drugs. D. Hypertension E.9, type 2 diabetes mellitus, Z.41 overweight, BMI 25.0, 29.9 and Z.43 OB, BMI 40 or higher. Answer A. Hypertension E.9, type 2 diabetes mellitus and Z.4 long-term use of insulin. Explanation: the patient's hypertension and type 2 diabetes mellitus (0.9) are active conditions, and the physician's note documents concerns for kidney function, which justifies the need for laboratory testing. However, the other codes for BMI or insulin use are not warranted unless explicitly documented. Question 22. A 65-year-old female patient with a history of chronic obstructive pulmonary disease, COPD, presents with an acute exacerbation, including worsening shortness of breath, coughing, and increased sputum production. The physician orders chest X-rays and prescribes antibiotics and inhalers. How should the coder assign the ICD-10 codes for this encounter? A. J.0 COPD with acute lower respiratory infection and J.9 acute bronchitis unspecified. B. J.1 COPD with acute exacerbation and J bronchitis not specified as acute or chronic. C. J.9 COPD unspecified and J.9 pneumonia unspecified. D. J.1 COPD with acute exacerbation and J acute nasopharyngitis. Answer B. J.1 COPD with acute exacerbation and J bronchitis not specified as acute or chronic. Explanation: the patient has an acute exacerbation of her COPD, which is best coded using J.1. The diagnosis does not specify a low respiratory infection or pneumonia, and bronchitis is not mentioned. The physician's documentation indicates an acute exacerbation, so J.1 is the most accurate code. Option is incorrect because it uses J.9, which is for acute bronchitis, which is not documented. Option C incorrectly uses J.9 for pneumonia, which is not indicated. Question 23. A 72-year-old male patient with a history of prostate cancer is being treated with hormone therapy. He presents with complaints of fatigue, muscle weakness, and bone pain. The physician performs a physical exam and orders lab work to evaluate the severity of the cancer treatment side effects. How should the coder assign the ICD-10 codes for this encounter? A. C. Prostate cancer as .51 long-term hormone therapy and M.5 low back pain. B. C. Prostate cancer Z.51 long-term hormone therapy and M.7 fibromyalgia. C. Prostate cancer as .89 other long-term drug therapy and M.50 pain in unspecified joint. D. C. Prostate cancer Z.52 long-term use of oral anticoagulants and .1 myositis. Answer A. C. Prostate cancer Z.51 long-term hormone therapy and M.5 low back pain. Explanation: the patient has prostate cancer and the use of long-term hormone therapy Z.51 is relevant in this context. The bone pain can be coded as M.5 low back pain due to the generalized muscle weakness and bone pain associated with cancer treatment. Options B, C, and D include codes for unrelated conditions like fibromyalgia or myositis, which are not supported by the physician's documentation. Question 24. A 40-year-old female patient with a history of anxiety disorder of .9 and depression of .1 presents to the psychiatrist for a follow-up visit. The psychiatrist documents that the patient is experiencing increased anxiety due to a stressful work environment and recommends adjusting her medication. The psychiatrist also suggests the patient participate in cognitive behavioral therapy. How should the assign the ICD-10 codes for this encounter? A. F.9 anxiety disorder unspecified at F.1 major depressive disorder recurrent and Z.5 disruption of family by separation or divorce. B. F.9 anxiety disorder unspecified and F.1 major depressive disorder recurrent. C. F.9 anxiety disorder unspecified F.1 major depressive disorder recurrent and Z.0 long-term use of benzodiazepines. D. F.9 anxiety disorder unspecified FF.1 major depressive disorder recurrent and Z.9 counseling unspecified. Answer B. F.9 anxiety disorder unspecified and F.1 major depressive disorder recurrent. Explanation: the patient's diagnosis of anxiety disorder of .9 and depression of F.1 are the primary concerns. The other options add unnecessary or unsupported codes. There is no indication that the patient is being prescribed long-term benzodiazepine C.0 nor is counseling as .9 specifically coded unless explicitly mentioned. Question 25. A 28-year-old male patient visits the emergency department with a suspected dislocated shoulder after a fall. X-rays confirm the diagnosis of A left shoulder dislocation. The physician provides a reduction procedure and a sling for immobilization. How should the coder assign the ICD-10 codes for this encounter? Point 2, a dislocation of left shoulder, initial encounter, and point 830, other location, unspecified. B. Point 2, a dislocation of left shoulder, initial encounter, DSS unspecified 4, initial encounter. C. Point 2, a dislocation of left shoulder, initial encounter, and point 1. Aftercare following joint replacement surgery. D. Point 2, a dislocation of left shoulder, initial encounter, and point 9, other reduced mobility. Answer: B. Point 2, a dislocation of left shoulder, initial encounter, diasis unspecified 4, initial encounter. Explanation: the patient has a left shoulder dislocation of point 2A in the encounter 4. A 4 should be coded with SS unspecified 4, initial encounter. While the physician did not mention a specific location for the 4, the dislocation is documented and requires accurate coding for the cause 4. Option incorrectly includes point 830, which is not applicable in this context. Option C is incorrect as it references aftercare for joint replacement, which is not relevant to the patient's condition. Option D refers to reduced mobility, which does not apply to the dislocated shoulder. Question 26. A 60-year-old female patient with a long history of osteoarthritis and M.9 in her knees presents for a follow-up visit for pain management. The physician documents that the patient's pain has worsened and that she is being considered for knee replacement surgery. The physician orders X-rays of both knees to assess the degree of joint damage. How should the coder assign the ICD-10 codes for this encounter? A. M.9, osteoarthritis of the knee unspecified, and Z.641, prosthetic knee joint left. B. M.9, osteoarthritis of the knee unspecified, and Z.1, aftercare following knee joint replacement. C. MM.9, osteoarthritis of the knee unspecified, and Z.810, encounter for pre-procedural examination. D. M.9, osteoarthritis of the knee unspecified, and Z.4, long-term use of insulin. And Z.C. M.9, osteoarthritis of the knee unspecified, and Z.810, encounter for pre-procedural examination. Explanation: the patient's osteoarthritis of the knee MM.9 is documented, and the encounter is for follow-up visit, which includes pre-procedural exams for potential knee replacement surgery Z.810. While other codes may be relevant if the patient has had knee replacement surgery, are not applicable here since surgery is not yet performed. Question 27. A 40-year-old male patient presents with symptoms of a severe headache, nausea, and vomiting. The physician suspects a migraine and prescribes medication for symptom relief. The physician also recommends the patient follow up in 1 week if symptoms persist. How should the coder assign the ICD-10 codes for this encounter? A. G.909, migraine unspecified, not intractable without status migrainosus, and R.9, headache unspecified. B. G.909, migraine unspecified, not intractable without status migrainosus, and G.1, vascular headache, not elsewhere classified. C. G.919, migraine unspecified with aura and R.9, headache unspecified. D. .909, migraine unspecified, not intractable without status migrainosus, and F.9, somatoform disorder unspecified. Answer A. G.909, migraine unspecified, not intractable without status migrainosus, and R.9, headache unspecified. Explanation: the patient's headache is most likely a migraine, and since there is no specific documentation to suggest the presence of aura or intractability, G.909, migraine unspecified, is appropriate. R.9, headache unspecified, is an additional code to describe the headache symptoms. Option B introduces a vascular headache code, which is not indicated, while option C refers to migraines with aura, which is not documented. Option D suggests somatoform disorder, which is not applicable in this case. Question 28. A 55-year-old male patient with the history of high cholesterol E.5 comes to the office for a follow-up regarding his hyperlipidemia. He has been on a statin medication for years, but his recent lab work indicates an increase in his cholesterol levels. The physician recommends adjusting his statin dosage and refers the patient to a dietitian. How should the coder assign the ICD-10 codes for this encounter? A. 0.5 hyperlipidemia unspecified, so 0.89 other long-term drug therapy, and Z.3 dietary counseling and surveillance. B. 0.5 hyperlipidemia unspecified, so 0.4 long-term use of insulin and Z.9 counseling unspecified. C. 0.5 hyperlipidemia unspecified, so 0.3 dietary counseling and surveillance. D. 0.9 disorder of lipopro metabolism unspecified, and Z.89 other long-term drug therapy. Answer A. 0.5 hyperlipidemia unspecified, Z.89 other long-term drug therapy, and Z.3 dietary counseling and surveillance. Explanation: the primary diagnosis is E.5 for hyperlipidemia, and Z.89 other long-term drug therapy is appropriate due to the patient's long-term use of statins. The dietitian referral is appropriately coded as C.3 dietary counseling and surveillance. Options B and D introduce codes for insulin therapy or lip protein metabolism disorders, neither of which are relevant to this patient's condition. Question 29. A 32-year-old female patient presents to the clinic with a complaint of frequent urination and dysuria. She has a history of urinary tract infections (UTIs). The physician diagnoses an acute cystitis N.0 and prescribes antibiotics. How should the coder assign the ICD-10 codes for this encounter? N.0 acute cystitis and Z.440 personal history of urinary tract infections. B. N.0 acute cystitis and N.0 urinary tract infection site not specified. C. N.0 acute cystitis and Z.89 other specified personal risk factors. D. N.0 acute cystitis and Z.9 counseling unspecified. Answer A. N.0 acute cystitis and Z.440 personal history of urinary tract infections. Explanation: the primary diagnosis is acute cystitis N.0. The personal history of urinary tract infections Z.440 is important to document given the patient's history and recurrent nature of the condition. Option B is incorrect because the N.0 code applies when the infection site is not specified, which is not the case here. Option C involves risk factors unrelated to the current condition, while D codes counseling that is not related to this encounter. Question 30. A 70-year-old male patient with chronic kidney disease stage 3, N.3, presents to the clinic for a routine follow-up. The physician evaluates the progression of his kidney disease and advises the patient to increase fluid intake and manage his blood pressure more closely. How should the coder assign the ICD-10 codes for this encounter? N.3 chronic kidney disease stage 3 and Z.4 long-term use of insulin. B. N.3 chronic kidney disease stage 3 and Z.81 exercise intolerance. C. N.3 chronic kidney disease stage 3 and Z.41 overweight, BMI 25.029.9. D. N.3 chronic kidney disease stage 3 and Z.0 general adult medical exam. Answer D. N.3 chronic kidney disease stage 3 and Z.0 general adult medical exam. Explanation: the patient's chronic kidney disease N.3 is the primary condition. A general adult medical exam Z.0 can be used for the follow-up encounter, especially if the encounter is focused on routine monitoring of the disease and overall health. Option includes a 0.4 long-term use of insulin, which is not applicable to this patient. Option B references a non-specific code for exercise intolerance, which is not documented. Option C references AI code, which is irrelevant based on the information provided.